So now we're going to look at OCD and the treatments of this. This is psychopathology. This is our final psychopathology lesson. This is on paper 1, along with memory, social and attachment. So before we start, let's do a little recap. So what I want you to do is list 4 keywords from the explanations of OCD, which we covered last lesson. I'd like you to define these keywords, then choose one and explain it in as much detail as possible. See if you can use it in a P or a PO paragraph. Okay, so some keywords that you might have might be SCRT, COMT, serotonin, dopamine, correlation, treatment, scientific, just a few keywords that you might have from last lesson. Again, I think I've mentioned this before, but it might help to have a glossary of keywords for each section. And I'll put together a little glossary for you to fill out for psychopathology and put that on the revision section. So we're going to focus on treatments for OCD. We looked at the biological explanation for OCD, so we're going to look at biological treatments for OCD. So we'll see here that we've got antidepressants and anti-anxiety drugs, which are the 2 main drugs that we use to treat OCD. So we'll start off with anti-anxiety drugs. An example anti-anxiety drug is a benzodiazepine, or you can refer to them as BZs in the exam. These are used to treat OCD because they reduce levels of anxiety. This is a little bit of science here, so they work by enhancing the activity of GABA, which is a neurotransmitter which inhibits the body's fight or flight response when it bonds with receptors. So these make GABA more effective and it reduces that fight or flight effect, so it stops your fight or flight response, or it slows that fight or flight response down, and therefore you can calm down quicker. There's some images of some examples there, so you might have seen Valium or heard of that before. That's an example benzodiazepine. So then we've got antidepressants. 2 types of antidepressants. We have SSRIs and tricyclics. So SSRIs are referred to as selective serotonin reuptake inhibitors. So basically they prevent serotonin going back into the pre-synaptic neuron. So they keep the serotonin in the synapse for longer. And this means that there's an increased chance of them bonding with the postsynaptic neuron and passing on that impulse. Then we have tricyclics, which are also known as TCAs. Again, you can refer to them as TCAs in the exam. These block the reuptake of noradrenaline and serotonin, so they work in a similar way to SSRIs, but because they affect more factors, they therefore have more severe side effects. So these are often a second choice treatment. So you would start off by being prescribed SSRIs, and if the SSRI wasn't effective, then you'd be given a TCA. There's some examples of antidepressants there that you might have heard of before. So Prozac is one brand of antidepressant which is quite popular and quite well known. So to recap, our biological treatments for OCD, we have anti-anxiety drugs known as benzodiazepines or PEMS, I'm not sure how you say it. You can refer to them as BZs. They enhance GABA and they reduce your fight or flight response. Then we have antidepressants. We have 2 types. We have SSRIs, which affect levels of serotonin. They increase the length of time that the serotonin is in the synapse, and therefore it bonds and passes on that impulse. And we have TCAs, and TCAs not only affect serotonin, they also affect noradrenaline. So these are more severe with regards to the side effects that they have. So now we're going to evaluate the treatments. So strengths of drug therapies. So we've got some research here that looked at the use of SSRIs with OCD patients. They found that they were more effective than a placebo in reducing the symptoms after 3 months of treatment. So it shows that in the short term they are very effective and they can help that individual. Using drugs to treat OCD is cheap and it takes less effort from the patient in comparison to CBT. which can take lots of weeks, and it can you have to do lots of homework with that. It's a lot of cognitive effort is involved, whereas if we give someone drugs, it's quick, it's cheap, and if the patient doesn't want to take part in cognitive therapy, or if they can't take part in cognitive therapy because it's causing them too much anxiety, then these drugs might be better to prescribe them initially. Then we have limitations of drug therapies. So there's lots of side effects linked to antidepressants and anti-anxiety drugs, such as nausea, headache, insomnia, which are the common effects of SSRIs. Tricyclics have more severe side effects, such as hallucinations and irregular heartbeat. Benzodiazepines can increase aggressiveness. They can lead to long-term impairment of memory if they're used for a prolonged period of time. Often, if you're having an anti-anxiety drug such as a BZ, you should only use it for a maximum of 4 weeks. So they're really effective in the short term, but they're not a long-term solution for the problem. Then we have some research that looks at the effects of drug therapy and OCD, and it suggests that it might just be treating the symptoms, not the cause of disorder, and this is because they can often have a relapse when they stop taking the drug. So it could be that there's an underlying cause that we need to focus on. It could be that drug therapies are better combined with cognitive therapy. So this is something that we mentioned before when we looked at depression, that drug therapies and cognitive therapies can be used alongside one another. It could be that you use the drug therapy to minimise the symptoms, and this puts an individual in a better position and a better mind frame to take part in some of the cognitive treatments such as CBT. They also have economic implications, these biological treatments. So if we have drug therapy and we find out that drug therapy is effective, then we can prescribe an individual with drugs, and we can make sure that they can go back to work, and therefore we can improve the economy because we have more people in work, and therefore we're making more money because they're paying more taxes, and that can be put back into the NHS. And also it could mean that individuals are less of a strain on the NHS because they're managing their symptoms using drugs. But again, that's not a long-term solution to the problem. As you can see, they're not always effective in the long term. It's more of a short-term treatment, and with BZs you can only give them for a short period of time anyway because the side effects are so severe. So just to recap our evaluation points: positive, they're effective, they require less effort, and they're quite cheap, so they're really easy for us to prescribe. They don't cost the NHS as much money as CBT. And then the limitations, so there's lots of side effects involved with SSRIs, TCAs and BZs. We could be treating just the symptoms and not the cause, and then we have some economic implications as well. So the economic implications, this idea that it's good because we can get people back to work, but then it could be a problem because actually we're only treating them in the short term, so then in the long term it could cost us more money. So it might be better to use drug therapy and CBT as a combined treatment. So then we have an exam question. It's an application question. So here we've got 2 different drug therapies, and these drug therapies are being tested on some patients. We have some results here, so we have the average, which is also known as the mean, and we have the range. And what I want you to do is have a look at this data and explain what they suggest about the different therapies. So therapy A and therapy B, what does this data suggest about them? Which one's more effective? Are they similar in any way, etc. Okay, so let's have a look at our mark schemes. So the mark scheme, we've got some information here. So the 2 averages or the means are very similar. This suggests that both therapies are as good as one another, so they're both effective. The range for each group, however, is very different. So for therapy A, it was very beneficial for some, but it didn't have a lot of benefit for others because that's got a really large range, whereas therapy B, there's a much smaller range, so it means that it's more consistent. So most people have a similar effect on improvement. Yes, the effect might not be as high as therapy A, but it's a more consistent effect. Okay, so finally what I'd like to do is complete the quiz on Classroom. Because this is the last section in psychopathology, what then I'd like you to do is complete a summary sheet for your revision. Maybe start up and go through a key term glossary, and then we'll do an end of unit test.